Hi everyone. Today I'm going to be giving a presentation for Anatomy and Physiology 2 about chronic obstructive pulmonary disease as we explore the respiratory system. First up, I'm going to give you a brief background on the respiratory system and the airflow pathway. So if you can see my cursor over here on the right, I kind of drew a quick little line that kind of explored the pathway a little bit. So we're going to start at the nose and mouth, and oxygen is going to flow in to the pharynx, down to the larynx, into the trachea, bronchi, bronchioles, and note that the bronchioles are the smallest air tubes, and they're going to split all the way into the alveoli, which are the small air sacs where O2 and CO2 transfer occurs. A little background into the respiratory system and the more major parts in COPD are the bronchi, which again are the airways, air tubes. If you can see on this right-hand side picture, the top part are the bronchi. The top left is going to be the healthy airway, the healthy bronchi, and it is seen by wide, large diameter and also efficient airflow. Another factor seen in COPD is an abnormal bronchi. So that is seen on the top right over here. You're going to have a thickened bronchi outer coat and also very poor airflow. Um, on the bottom here, we're going to explore the alveoli, where again CO2 and O2 transfer occurs in the air sacs. On the bottom left over here, you're going to have many small sacs, which allow for efficient CO2 and O2 transmission and very easy breathing, as you do now. And on the bottom right here, we're going to have abnormal air sacs of the alveoli, which is seen as emphysema. Um, that's going to have very poor CO2 and O2 transmission and a lot of difficulty in breathing. So, what makes up COPD? Again, like I said earlier, emphysema, which is the lung tissue destruction of the alveoli. The lungs become damaged and stretched. Symptoms include chronic cough, dyspnea, and there is no cure. And the second pillar of COPD is chronic bronchitis. That is going to be swelling and inflammation in the bronchioles and airways. Symptoms include cough, wheezing, difficulty breathing, and heavy mucus production. Again, no cure for this either. The third pillar is refractory asthma. That's going to be inflammation of the airways due to outside factors. This could be pollution or anything like smoking, something like that. Symptoms include swelling / tightening of the airways, trouble breathing, and again, no cure. But I want to highlight that even though it says no cure, that doesn't mean that we can't resolve some of the symptoms. So with medicine, we can kind of ease the coughing, ease the wheezing, ease the heavy mucus, etc. But again, there's no cure. We can't get rid of it completely. So what are some of the risk factors for COPD? The main one that is highlighted through many studies is smoking, which damages the air sacs and airways and the lining of your lungs, leading to COPD. The second one is going to be pollution or chemical exposure, which is comorbid with asthma. That is because pollution induces onset acute asthma, which exacerbates COPD, which can lead to respiratory morbidity and or mortality. Another rare, not really in your control factor is AAT, which is a rare genetic disorder. The body has an inability to protect against respiratory inflammation. And again, COPD is an inflammation of the bronchioles and the bronchi and the lungs and the alveoli. So my future is going to be in oral health, so I'm going to explore COPD and oral health. And what I found is that oral health hygiene has a direct link to COPD. I'm going to kind of look at before you're diagnosed with COPD and after. So pre-COPD, many of these patients have poor oral health from risky activities, which could be smoking, poor diet, etc. The poor oral health equates to worsening effects if diagnosed with COPD in the future. And then after you have COPD, as you're going to see later, is that a lot of the microbiome in the lungs and the mouth are the same. So with that, you have an attachment loss of gingiva, which is your gums, increased plaque and calculus, increased depths of dental pockets, again because of the bacteria, increased teeth loss, and increased OHIP score. The OHIP score is just how a dentist's overall ranks your oral hygiene, and an increased score means poor oral health. Increasing oral hygiene has been shown to potentially decrease adverse lower respiratory tract issues, which is awesome. And I kind of created this pull the tooth method. As I explored more, I saw that the lung microbiome is also present in the oral cavity, and if you think about it a little bit, um, they're connected in one tube, so it makes sense for the bacteria and to be the same in both the lung and the mouth. So I found that they have in common COPD patients in the lungs and oral microbiome. They have an inflammatory bacteria of 16S rRNA sequencing, which is highly present in COPD patients. I wrote the three bacteria here. I won't try to say them for you. Um, and I found that the more teeth you have as a COPD patient, the increased COPD symptoms. I found that very interesting. And my only theory behind that is that the increased number of teeth that you have, the more susceptible you are to bacteria growth and plaque, um, giving these three bacteria a great place to grow, thus exacerbating the symptoms of COPD. When providers extracted the teeth, however, in the diseased patients, they removed the pro-inflammatory bacteria, and as they studied their dental pockets for bacteria over time, they saw a decrease in COPD symptoms, and they concluded that's because there was no more bacteria there to increase the symptoms. This is an area of dentistry, however, that is very understudied and all very theory-based. So does correlation equal causation? I think only time will tell with that. So again, COPD and dentistry. My name is Luke Bertrand. My major is health sciences, and my field of study is dentistry. And I found that many COPD patients partake in risky activities, i.e. smoking, which can be identified and addressed within the dental office. So a lot of people are saying it's the dentist's role and responsibility to address COPD patients early on as they see their people are taking part in like smoking, etc. Patients diagnosed with COPD have symptoms of shortness of breath, productive cough, upper respiratory infection, and oxygen saturation less than 91%, which is interesting in my last slide that I said pull the tooth because with these symptoms, it restricts a lot of dentists from performing routine care and or surgeries because it can obstruct their breathing patterns. However, if they have stabilized breathing patterns, some dental procedures can be performed. But even if the dental procedures can be performed, it restricts a lot of medical providers to reduce medicine usage, including avoiding bilateral mandibular block and or bilateral palatal block, which this is important because it can constrict airways. There can be no rubber dam usage because of airway constriction. No to low usage of sedative medicine, as it may disrupt breathing patterns. No narcotics because it can cause respiratory depression. No antihistamines because it can cause dryness and or increase mucus density in the airways, again disrupting the breathing pattern. And all these make it really hard for practitioners to treat people with COPD because we can't really solve the problem because we can't really intervene with medicine. And this one's for you, Brian. This is our gut microbiome. Some quick facts under here. The gut has 99% of the human microbiome populating the small intestines, which directly aid in digestion and indirectly aid in immunity and inflammation. I want to highlight inflammation here because, again, COPD is really important in inflammation. That's the main cause of it. The gut microbiome has a global effect, and I also found that the lung microbiome closely resembles the gut microbiome. So by helping one, you help the other. Um, Examination of the gut-lung axis is kind of exploring how the lungs and gut interact in microbiomes to either help or detriment each other. COPD has many comorbidities, and one of the main ones I found is that um, a lot of patients have poor nutrition, um, and their increased cough slash sputum production, airflow obstruction, and inflammation can be caused of the fiber gap. Um, And I'm going to scroll down a little bit to this bottom section over here. I'm sorry I have it out of order, but it might help the flow a little bit. So the fiber gap is important because by increasing fiber, you increase the production of short-chained fatty acids. And these act as anti-inflammatory molecules, reducing chemotaxis and adherence in immune cells. This increases anti-inflammatory cytokinins, thus increased apoptosis of negative cells. It assists in preventing COPD or eliminating many symptoms post-diagnosis. Again, inflammation is a huge factor in COPD, so by reducing this inflammation, you can reduce some of the symptoms. And fiber has been seen to be really good at reducing inflammation by producing shorty chain fatty acids. And what was proposed was a prudent diet. In the prudent diet, you have frequent intake of vegetables, fruits, oils, dressings, whole grains, rice, pasta, fish, low-fat dairy, poultry, and water, which are high in fiber. And this kind of contradicts the Western diet that we all experience now, which is high in red processed meats, saturated trans fats, refined grains, processed sugars, and beer and spirits, which are low in fiber. So by going to the prudent diet, you have increased fiber uptake, thus increased short chain fatty acid uptake. These are all my references, and if you have any questions, let me know. Thank you.